I'm back in plenary session, video edition, joined by Josee-Lyne Ethier. Josee-Lyne is an assistant professor at Queen's University, Kingston, Ontario, Canada. Josie, it's a pleasure to have you join us on the podcast.
Thanks for having me.
You've got a new paper out now, JAMA Oncology. This is entitled Practice Patterns and Outcomes of Novel Targeted Agents for the Treatment of HER2-Positive Metastatic Breast Cancer, a population-based study. It's a very interesting paper, and we're going to run through it on today's episode. Thank you so much for doing this.
Thanks again for having me. I'm really happy to be here and talk about the paper.
And it's out now, JAMA Oncology, on July 8th. So this is an interesting paper. Of course, folks, your background is in breast and gyn oncology. And folks who work in that space will know two pivotal randomized controlled trials that shape our therapy. One is Cleopatra. Cleopatra, of course, is Pertuzumab, Trastuzumab, and taxane against Trastuzumab and taxane in frontline newly diagnosed metastatic breast cancer, which had an initial PFS benefit, I think, in the New England Journal paper, and then later had the OS benefit in another paper. One of those is a Baselga paper. One is a Sandy Swain paper. I can never remember who's the first author on which one. And then the other study is Emilia, which is a TDM-1 study, which was TDM-1 versus, was it lapatinib, capecitabine?
That's right, capecitabine and lapatinib.
And that also has an OS benefit in a subsequent line of therapy.
It does.
Okay, so these are the two studies that are practice changing for folks in your discipline for HER2-positive breast cancer. Is that fair to say?
Yeah, absolutely. I was a resident sort of when these papers came out and when they were really adopted into practice. And in Canada and Ontario, where I trained and practiced, where they were actually approved for funding reimbursement. And I remember as a relatively young trainee, a lot of hype around these papers. Mm-hmm. You could kind of feel the excitement with these drugs coming in and, exciting stuff, right? Like new treatment options for our patients and just, OS benefit. Really practice changing.
Yeah. So would you say that if you have a de novo metastatic patient with HER2-positive breast cancer, received no prior treatment, you're going to initially start with Pertuzumab, Trastuzumab, and taxane?
That's correct. I think that would be considered the standard first-line treatment in Canada and the US and really across the world. Based on the Cleopatra data.
Okay. Yes. Based on this study, which we're going to talk about in your very interesting real world study that looks at this. But I guess the other question I had for you is what's your adjuvant practice like now? Have you pulled Pertuzumab to the adjuvant space? In this country, we're very eager to do that because it's what put food on the table. But what about in Canada? I actually don't know.
Yeah, it's interesting, with some of the studies that have looked at Pertuzumab, especially in the neoadjuvant space, that didn't necessarily translate to an overall survival benefit. It's not reimbursed in Canada. And now with some of the, with the Catherine study looking at TDM-1, which, in the metastatic setting is from the Emilia study, looking at its use in patients who received neoadjuvant chemotherapy and had residual disease. We're able to obtain it through some access programs. It's a bit of a stay tuned situation in terms of funding. So it's always a little bit interesting when we talk about the US landscape versus Canadian landscape, because for us, it's really like a little bit of a two-tier practice change. First you deal with the approval of the drug, and then we deal with reimbursement, because I would say it's probably a minority of our patients who are able to access, funding to drugs through insurance if it's not reimbursed by our single payer public healthcare system.
Yes, you have some rational checks and balances that we don't have in the U.S. We've got to run up the tab here. We got to run up the tab. So, but I guess what I'm getting at is that in your study, when you talk about people with newly diagnosed or people with metastatic breast cancer getting initial treatment, they're getting Pertuzumab, Trastuzumab, and taxane, they're Pertuzumab naive for the most part. They haven't gotten Pertuzumab.
For the most part, yeah.
Okay.
Really, I would say the majority of our patients, I think we have in the paper, it would be a very small amount of patients who would have received, you may have patients who have, had a recurrence versus de novo metastatic disease who have had Pertuzumab in the adjuvant setting, but that would be a small number of patients. Yeah.
And then why don't you talk about the Emilia study? The Emilia was the second and subsequent line, wasn't it? It was more than just second line.
Yeah, so it really in standard practice, I think now it is considered, especially if you're talking about the more straightforward situation of a patient with de novo, metastatic breast cancer who would receive the first standard line of pertuzumab in combination with trastuzumab and taxane, and would receive TDM-1 trastuzumab emtansine as a standard second line. Mm-hmm. Now, of course, keeping in mind that at the time that Emilia was done, and this is kind of where a lot of my interest came in this drug, and how are we using it? What do we know from it? You're correct that there was a not unsubstantial subgroup of patients that were receiving it in a later line. Mm-hmm. But the really interesting part is that none of those prior lines included pertuzumab. These were really pertuzumab naive patients, right, because these studies were conducted almost concurrently and were published, in a relatively close timeline.
I see. That's important to know, and that'll have relevance for your paper. I guess the other thing I want to highlight is that, of course, Cleopatra, pertuzumab, trastuzumab, and taxane versus trastuzumab and taxane, it has a PFS benefit and an OS benefit, and the OS benefit is big, and you can tell us what the specific numbers are. But one of the criticisms of this study that I had heard and that was said at the ODAC for when pertuzumab tried to get into the neoadjuvant space was that the control arm patients in Cleopatra, not all of them received HER2-directed therapy past progression. And in the US, by this time, we had already started giving people, trastuzumab and taxane, but you progress. We continue the trastuzumab, really till death do you part, indefinitely. And in Cleopatra, they didn't do that. Of course, that will penalize the control arm and maybe artificially inflate the delta. But what you're looking at is just the absolute survival in real-world people in Ontario who get this triplet versus the people on the Cleopatra study who got those three drugs. So I wonder if you might tell us how long did women live who got pertuzumab, trastuzumab, and taxane in Cleopatra? What was the median OS? And what did you find when you looked in your cohort? Yeah.
Yeah, so on Cleopatra, on the experimental arm that included pertuzumab, the median overall survival was 57 months compared to a control arm of 41 months. Whereas in our paper, when we looked at, we were looking at a cohort of women who received pertuzumab for metastatic breast cancer, a combination with trastuzumab and, of course, initially a taxane. And the median survival that we saw was shorter than the 57 months that was seen in Cleopatra. So what we saw was a median OS of 43 months.
Interesting. That's a bit lower. It's a bit lower. 57 goes down to 43.
Yeah, which, again, with looking at real world data, and, you've talked quite a fair bit with my colleague, Chris Booth, who's also a co-author on this paper, and, talking about issues of generalizability and really with clinical trials and efficacy, effectiveness gap. This is really not that surprising, to see. It's still, 43 months is not, it's nothing to, it's still certainly a substantial survival, but lesser than what we saw in the trials. And again, not that surprising, given that we know that there can be generalizability issues with data from trials when we look at real world populations and what we're actually achieving.
Yes. And in addition to the OS, the time on treatment, I wonder if you might talk about this. So your time on treatment in the real world versus Cleopatra, what was the time on study drug in Cleopatra?
Yeah, so really, we use time on treatment as a surrogate for progression-free survival, which is can be difficult to ascertain or really impossible to ascertain using real world data. So on Cleopatra, there's a median progression-free survival of 19 months on the experimental arm, whereas time on treatment in our population was 14 months.
Right.
So again, we're not doing a direct comparison here. We're really using Cleopatra data as our historical data, but shorter.
Yes. And you did one further analysis where you tried to pull out amongst the real world patients the people most like Cleopatra trial participants. I wonder if you might talk about that.
Yeah, so we looked at our population, and again, with this issue of generalizability and kind of trying to get a sense of, why are we seeing, we talk about differences in population, but what's really at play. And we noticed that our median age in our cohort was in our pertuzumab cohort was 57 years old,
Right.
whereas on Cleopatra that was 54. And based on our Cox models, age certainly appeared to be a significant predictor of survival, as we could have guessed, right? It makes sense. But it was interesting. So what we actually did is to try and approximate a population closer to that of Cleopatra. So we derived an expected survival based on a Cox model where we set the age at 54.
Sure.
And that actually improved our expected survival to 53 months, which of course is closer to what we would have
but still
expected.
falls short. Still
falls short.
Yeah.
But I found, I was actually surprised when we did that model, right? Because you look at our ages in our population, 54 median, 57 median, it's a difference, but it's not as though we were looking at a median, at an elderly population, right? It was not that far off. So really to show just, to me, it really highlights this issue that we can see with generalizability, with even a 3-year median difference in age in our cohort versus a trial cohort, is a significant driver. Looking at these are estimates, of course, from models, but a 10-month difference in what we can expect to see. And it really, drives home for me when we look at this data from clinical trials and then try to apply it to our population, both for policy and reimbursement, but even for simpler things like informed consent discussions with patients using these agents, that it's not as easy as saying, well, these are the numbers in clinical trials and that's what I can expect in my patient.
It is actually, I must admit, it even surprised me, because if you told me your real world age was 63 and the trial was 54, then I would believe it. But 57, 54, that's not that far apart. And yet to see sort of such a significant proportion of the overall survival decrement that is corrected by merely the age coefficient, I think I must admit I was surprised. And it does speak to, I think, your point. It must have surprised you too. Because it's just a few years.
Yeah, absolutely. And I think, the kind of key take home for this cohort, for the pertuzumab cohort, is that, this isn't, this is in no way invalidating the data the results that we saw from Cleopatra, right? It just really goes to show, it's not to say that I think pertuzumab's a great agent and one that I will certainly, continue to use, but it just really goes to show how, you can have a great drug and use it in one population and then use that same drug in a slightly different population, and you're not going to get reproducibility.
Yeah, and I think we'll come back to this because I want to talk about this more, and maybe I'll hit them a little harder than you're hitting them. But I guess my point is that, what you're showing is that the OS itself, the raw OS, is shorter, significantly shorter. And that speaks to the fact that they ran their trial in people who don't look like average Canadian people who are going to get using this drug. So it's a failure of the trial, I think, to some degree, to actually run the trial in the people who are actually going to get the drug. But what you haven't been able to do, and this is a limitation of the way the data is you haven't been able to see what's the delta of this drug in the real world, because there is no clean counterfactual, and there are ways we could kind of get at it. But if one even assumes the same hazard ratio as in Cleopatra, it will be smaller than what was observed in Cleopatra, which, if I recall, was a 15-month OS gain in Cleopatra. Something like that.
16.
16.
You're close.
Yes, the famous 16 month. They love to celebrate that. But even if you assumed it had the exact same hazard ratio with your baseline rates, you're probably talking 10 month, 12 months, something in that ballpark, I would imagine. Let's talk about Emilia before I actually have the solution to all these problems. I can fix this whole problem. But okay, let's talk about Emilia. Emilia is even more interesting to me because Emilia is a randomized trial that has changed practice. But now if people are but it's changed practice in a way that it's even less generalizable, because now we give pertuzumab before, and they didn't have a lot of people in that trial who had previously gotten pertuzumab.
And no patients in that trial.
Zero, yeah.
They were pertuzumab naive patients, right? So, and again, I remember when the study, came out. I remember when we got approval for the drug and started using it, and kind of being, relatively early in training, and kind of, this is a question I've been having in my head kind of ever since that time of, okay, so, how are we using this in this setting? Well, now all of our patients are getting pertuzumab, already seeing, questions of, beyond even generalizability possibility, but really you're using the drug in a different setting from where it was studied. But you carry on and you use the drug because that's what the practice is, and that's what the standard practice is. But really, you've always kind of wondered, we're not talking about huge OS gains with we could talk a whole other conversation about what's clinically meaningful and who should answer who's the best person suited to answer that question. But we're talking about, depending on whether you look at the intention to treat population or the kind of pre-crossover time point, you're looking at a 4 or 5 month overall survival benefit with this drug in a population that was pertuzumab naive.
Yes, and that's important. So, of course, it was this drug against ziloda-lapatinib, which I will say that at the time I think people thought it was the weakest comparator, the control arm. I mean, you could have pushed trastuzumab, or there were even other strategies at the time. Nevertheless, it had an OS benefit, and I guess that's commendable because for HER2-directed second line, I think actually to date, is it the only one that's ever had an OS benefit in second line, or did tucatinib pull it off? I can't remember. It might still to date be the only second line drug with an OS benefit.
I think that it is. I would have to see what's been updated with tucatinib, which again we can talk about comparators and questions around that.
But tucatinib, yes, a trial where you have a drug with blood-brain barrier penetration, and of course the right thing to do is put it up against a drug without blood-brain barrier penetration and enrich for a brain disease. Sure, tucatinib, yes, I got some problems with that study. I think I discussed it on this podcast. Okay, we'll come back to that. So what you were interested in looking at was the OS of people getting TDM-1 second line. And you knew something, which is that in your cohort, a lot of people are going to have previously seen pertuzumab, so they've had more HER2-directed therapy than the people in Emilia study. So what was the OS in Emilia, and what was the OS you observed for TDM-1 in the real-world Ontario province?
Yeah, so the OS that we saw in Emilia was a median OS of 30 months. Whereas what we saw in our TDM-1 cohort was a median overall survival of 15 months. So half.
Wow. That is a big difference. Difference. And here also, now what are you going to say the same thing about pertuzumab? Because here, do you really know if after someone has gotten pertuzumab, is TDM-1 better than alternatives? What are your thoughts?
I don't know that we can answer that based off of this study. I don't know that we can answer that based off of any study, right? I think, time will tell us, now we've got all of these new agents, trastuzumab deruxtecan, tucatinib kind of coming into play, and as they will, likely move forward in the sequence, and we'll kind of see where they land. I don't think that I could, take from this. Certainly it starts to raise those questions though, right? As you see, good outcomes coming through with some of the still currently later line agents. But when you start to call into question some of the benefit from TDM-1, certainly raises that question.
Yes. I think it was both of these are very provocative findings. Of course, one, they tell us something we've known all along, which is there is this efficacy effectiveness gap, which you write eloquently about in your discussion. But two, I think that the extent of the gap is what kind of surprised me, particularly for the TDM-1. That is far less OS than I would have guessed. And again, even if one assumes the exact same hazard ratio, the absolute benefit is lower, which means the cost effectiveness is much more unfavorable, which is something that people forget. Let me try to restate that. My point is that there are two moving parts. One is, in the real world, people aren't living as long as in the trial. Okay. The drug could still have the same benefit over not giving the drug as in the trial. But if you assume both those things are true, that it still has the same proportionate benefit, but people aren't living as long, you have to assume that the absolute increase in survival from the drug is smaller. And if the price ain't cheaper, the price is the same price. So the cost effectiveness is going to be more unfavorable. And so I think, places like your Canadian payers should immediately take this data seriously to rerun their cost effectiveness analyses to see if these drugs still are favorable. I think that's one simple thing they can do. I don't know. You had many sort of really eloquent points in your discussion. I wonder if you might, what do you think is the most important for listeners to know?
Well, I think before even getting into,
Okay.
further discussion around it, like the really, so I had the same reaction as you when I saw the median OS and looking at it and saying, okay, it's cut in half. But then we kind of delved into that more and said, so we had both patients that were pre-treated with that had received pertuzumab as a prior line, and we had pertuzumab naive patients. About 64%, I believe, of our cohort had received prior pertuzumab, and that increased over time, as you would expect, right? As
Sure.
pertuzumab kind of came into approval and came into funding. So when we kind of broke down that overall survival, that 15 months, and we looked then at trying to we can't compare them, but at least describing in patients that had previously received pertuzumab and those that were pertuzumab naive, what we found was that the median survival in the pertuzumab naive patients, which would have been the patients most similar to those treated as part of Emilia, that median survival was a little bit better. It was 19 months, still not a 30-month, but better. But what we saw was that in the pre-treated patients who had received a prior line, including pertuzumab, trastuzumab, and taxane, their median survival was actually shorter. It was 12 months. So you're looking at a 6-month difference really in terms of the median outcomes that you're observing in these patients that are pertuzumab naive, similar to the patients on Emilia. And then you're having a 12-month, 6 months shorter median of 12 months overall survival in these pre-treated patients that were not represented at all in Emilia, but that actually represent the majority of patients that are now receiving this drug.
Correct.
So ultimately, you have a drug that showed, a 4 or 5 month survival benefit in a certain setting of pertuzumab naive patients.
Yes.
And now we have data, descriptive data, but still, data from the real world patients that we're treating, showing that the majority of our patients, these pre-treated patients, have substantially shorter survival than those that would have looked like the patients from Emilia.
Put another way, the more you give pertuzumab, which doctors are giving more and more of, the less well your TDM1 is working.
It certainly raises the question of whether pre-treatment, treatment with pertuzumab or receipt of pertuzumab in a prior line decreases the efficacy of subsequent treatment with TDM1.
I guess I would say, yes, it raises the question. Can it prove? I think you have enough data to say for certain that the delta TDM1 is not the same delta. It's got to be a smaller delta than it was in Emilia. The absolute improvement in that cohort, in the pertuzumab cohort, because the absolute numbers are just so pitifully lower than the observed numbers in Emilia. But your point is more fairly stated. I mean, more appropriate nuance. You're a good scientist. But I'll push the hard thesis, which is that I think another way to put it would be a TriList could realistically have equipoise to test again whether or not TDM1 is preferred in subsequent line after initial treatment with pertuzumab.
I would fully agree with that. There's limitations to the data. It's real world data. It's not meant, we're describing the outcomes in a cohort. We're not doing a comparison here. We're kind of doing comparison to historical data. That being said, we did try to delve into it a little bit to kind of look and see, okay, well, what's going on here? What bias could be there? Similarly, when you see the same thing when you look at the time on treatment, right? Yes, so looking, kind of looking at this, and is this survival time bias? Is this just that we're, identifying patients with more aggressive disease? Right. Well, what we saw is really that the time on treatment, overall in the TDM1 cohort, it was 4 months, which again is less than, the almost 9.6 months that you're seeing with PFS on Emilia with TDM1. But when we break that down into the pertuzumab exposed patients and the pertuzumab naive patients, you're looking at 8 months and 3 months, really showing that this isn't just, people with more aggressive disease or people that have, already, lived longer on prior treatments, but that there's a difference in terms of, treatment was not prescribed here. This is, when we're assuming this is not a very toxic drug, that there's going to be a low number of people that are discontinuing treatment due to toxicity, right, due to non-progression. And we're seeing, numbers that look substantially different here in terms of how long people are staying on treatment based on whether or not they've been previously exposed to pertuzumab.
Yes, that's very well put and very well shown in the paper. Okay, I got 2 ways that I'm going to solve all your problems for you. No, okay. So one thing that makes me think about is a paper we wrote a couple years ago called "Should Evidence Have an Expiration Date?" And what do I mean by that? In oncology, in several places, we've seen transformation in the frontline therapy. So for instance, in liver cancer, people are moving to atezo-bev. In kidney cancer, people are doing axitinib pembro, axi-pembro, cabo, nivo. Pembro, whatever the hell, there's some TKI Pembro combo. They love these things, and Nivo, Ipi, all these things. So I guess one point I want to make is something that you've observed, which is that Emilia, subsequent line studies are run based on what people who enrolled in that study, what they had previously received. But once you change the frontline therapies in a disease, that evidence should have an expiration date. You should reassess the subsequent line therapies. You are showing evidence that they almost surely have a smaller delta, but it's possible the delta has vanished entirely because now all these patients are heavily pretreated. They're getting more drugs up front. You're nodding. You agree with this general thesis that we got to, in all these tumor types, we got to revisit the second line treatments.
Yeah, and it's tough, right? Because, and maybe that is the right answer. I've asked myself in looking at this data and, okay, well, what could we have done differently? What should we do differently in the future? And it's difficult because trials and research and oncology move quickly, and that's a good thing. Not always an easy thing if you're in, clinical trial design, right? Where you can set out to design the best study, and then another drug kind of comes into a different line, and all of a sudden your data's, isn't, you're not looking at the current practice setting. Correct. And your data's, is it expired? Obsolete. As you said, expired, is it obsolete? Yes. But I don't disagree with that in concept. How can we kind of apply that to practice? And that's certainly something to think about further. But I agree with you. I mean, I think if you change the prior treatments, you can't just make the assumption that you're going to have the same benefit from your drug if you're no longer using the same prior treatments that were being given at the time that your study was conducted. It just it makes common sense that you can't make that assumption. Yeah. And I think this is part, we do show that here.
And I think it's also particularly relevant because trastuzumab is going biosimilar and Xeloda is generic. And so it could be a lot cheaper if Xeloda is just as good subsequent line. Okay, then here's how I'm really going to solve your problem. I mean, I think the kernel of your problem, not your problem, but the problem that is in the world that you are astutely putting a finger on, which is that we in oncology, we got to take care of people who are the average Canadian, the average American, the average person in our country. That's who comes in our clinic. We don't get to say we only take care of trial eligible people in our clinics. We take care of everybody. And we rely on trials. And trials have a lot of explicit inclusion and exclusion criteria, from liver function to, you name it. They had to, sometimes some of the inclusion criteria is they had to have had a biopsy. That you can get to the tissue and look at it. They have to have measurable disease. So some bone-only patients, sometimes they get pushed aside. Sometimes they push out, some people with CNS disease. And then there's the implicit inclusion criteria, which is they have to tolerate this barrage of study entry without having rip-roaring progression. Otherwise, you wouldn't think about the trial. You just have to treat them. So there are all these sort of implicit and explicit criteria. What it does is it means that very small differences, like the difference you observed in age, 3-year difference, translating into 10-month different OS. It's very different. And, a few years ago, we wrote a paper that said like overall survival in a clinical trial with that population is a surrogate endpoint for overall survival in the real world, because it might correlate, but doesn't always correlate, So here's the solution that I had. And I thought of this, because of recovery trial. And Rahul Banerjee and I wrote a paper called Pragmatic Trials with Pre-Specified Subgroups, What Oncologists Can Learn from COVID. Okay, it came out in Nature Reviews. Here's the gist. The gist is, the way to solve this problem is you need to randomize average people, not just trial people. That's the way to solve the problem. You need a way of randomization when you run a trial where you're just randomizing everybody. You're randomizing with very little to no inclusion criteria because you want to know how the drug will work when you actually give it out the way you give it out. Yet, the legitimate concern might be that maybe there is this cohort, people with, say, Child-Pugh A, perfect, pristine liver function, or people who are a little bit younger and a little bit healthier than the average HER2 positive patient, who maybe we want to know that like they might benefit from the new drug, even if other people don't benefit, and we can have personalized medicine and use it appropriately. And so what we said is that the recovery trial for COVID actually is like the greatest way we can solve both problems. Recovery randomizes thousands of people, and they're very aggressive. They randomize a large fraction of all the people hospitalized. I think, I forget the precise numbers in the paper, like 11% of all hospitalized people in the UK were randomized on recovery, which is amazing. So they have very little filter to who they randomized. And then their power is so big, not only they can ask, is dexamethasone work in everybody, but does it work in pre-specified subgroups? Like, does it work if you're on the vent? Does it work if you're on O2? And does it work if you're not on O2? And the answer is, yes, it works on the vent a lot. Yes, it works if you're on O2, but actually it's maybe deleterious if you're not on O2, right? So they answer that question. So we could do the same thing in oncology. We could just say everyone's seeing HER2 positive breast cancer. We're going to randomize all these patients. And then we're going to ask, does it work in the average Canadian, the average American? Does it work in Canadians younger than 60, Canadians with perfect bilirubin, Canadians with perfect, all these things? And we can actually separate, maybe some of these drugs have benefit in ideal scenarios, and we should know that, but they don't have benefit as we get into older ages or people whose livers aren't pristine and those sorts of things. And then we can have real personalized and precision medicine. Any thoughts?
Well, I think that would be a great solution, so long as then we actually pay attention to the pre-specified subgroups
Yes.
and don't have a primary outcome in all comers, and use
Yes.
that to approve the drugs in everyone, despite the outcomes in our subgroups, right? Which then I'll get into a whole other pet peeve and problem that I think we deal with in oncology. But I think, having these pre-specified subgroups and associated endpoints, and actually using them to make decisions around who we treat and what drugs we pay for, would be great. I think even in talking about, prior treatments, right? And there are some studies now, let's say in breast cancer with, AKT inhibitors that are allowing, patients on study whether or not they've received CDK4 and 6 inhibitor. And that's great that's, pragmatic in terms of the eligibility, and that there's, I believe, a plan to incorporate that in pre-specified subgroups in the analysis. And then I think we just have to, from there, actually use that to inform who we're treating. I think that, that could have, if that had been possible in Cleopatra or in a post-Cleopatra study, in a post-Emilia study, I should say, wrong study, that would have resolved a lot of the issues that we're kind of delving into here.
Yeah, that's well put. Yes, I think we need that commitment that people actually look at these things and think about them and use them appropriately, and not just give blanket approvals. But that's a bigger problem. I have a solution for that too, but I'll leave that for interested readers of the book *Malignant*. I'll give you the last word, Dr. Ethier. It's a very elegant paper. It's well done. It's out in JAMA Oncology. Practice patterns and outcomes of novel targeted agents for the treatment of HER2 positive metastatic breast cancer, population-based study. It's getting at the greatest and most important thing in oncology. I think the difference between pivotal trials and our real practice. I'll give you the last thought. Thanks for doing this paper.
No, thank you. I think ultimately, this isn't necessarily saying that we need to, change our practice immediately. And I think, it draws the conclusion that you can draw from real world data, which understandably, we are aware has limitations. But I think to me, it highlights, things to consider in terms of future trial design, but also, when we're looking at making, treatment decisions for our patients and having informed consent, conversations with patients, or making decisions around, approval and reimbursement. I think it's very important that we not forget, as you said, that maybe there is an expiry date on studies, and that maybe the decision that we make at one time point, we need to continue to reevaluate down the line, because even if that was the right decision to make a few years back, that doesn't mean that it continues to be if the setting has changed.
Yeah. Thank you so much for doing this.
Thank you for having me.